Picture this. You wake up one morning, and over the course of just 3 short weeks, your belly swells up so much that you've gained 12 pounds. Literally, it's like suddenly carrying a bowling ball around in your abdomen. You're breathless the second you lie down, and you feel entirely stuffed after taking just a few bites of food. Now, this isn't just some minor bloating. It's a massive, mysterious accumulation of fluid. So what's happening? Is your liver failing? Is your heart struggling to pump? Or is it something else entirely? Well, meet Nora, a 58-year-old patient who's about to take us on a pretty fascinating medical detective journey.
Welcome to The Explainer. Today we're going to unravel the incredibly complex mysteries of cirrhotic ascites. We're going to see how medical professionals can uncover hidden secrets of the circulatory system, the liver, and the immune system using nothing but the clues hidden in a single tiny fluid sample drawn from the abdomen. It's honestly a masterclass in how the human body's plumbing actually works, and, well, how it completely fails.
Here's how we're breaking this case down chronologically. First, we'll meet the patient. Second, we'll look at why the fluid builds. Third, we'll decode that fluid. Fourth, draining the ascites. And finally, number 5, the infection plot twist.
Section 1, Meet the Patient. Nora's Mystery. Okay, let's dive right in and look at the facts of our case. Here's what we know about Nora. She's 58 years old and was diagnosed a couple of years ago with cirrhosis stemming from metabolic dysfunction-associated steatotic liver disease. And she has suddenly gained 12 pounds in 3 weeks. On exam, her abdomen is incredibly tense and distended. When her doctor taps on her sides, there's shifting dullness, which is a classic physical sign confirming she's got a massive pool of free-floating fluid in her abdominal cavity. Also, definitely keep an eye on her medication list. She takes lisinopril for her blood pressure and ibuprofen for her achy knees. We are going to come back to those later, because they're actually a huge piece of this puzzle. But right now, our immediate job is to figure out exactly why her body is suddenly retaining so much fluid.
Section 2. Why the fluid builds. The portal hypertension cascade.
To really solve this mystery, we have to understand the biological chain reaction that literally forces fluid to weep into the peritoneal cavity. It's an incredible domino effect, and it starts in the liver. Because of Nora's cirrhosis, her scarred liver creates massive resistance, causing a pressure backup in the portal vein. We call this portal hypertension, specifically a pressure gradient over 5 millimeters of mercury. In response to this crazy high pressure, the body desperately releases vasodilators, like nitric oxide, trying to open things up. But it totally overcompensates. The blood vessels around the gut, the splanchnic circulation, dilates so much that blood just pools there. And because all that blood is pooling in the gut, the rest of the arterial tree is suddenly running on empty. The brain and kidneys, they completely panic. They sense this drop in arterial volume and think, oh no, we're severely dehydrated. So in a desperate attempt to save you, they activate hormones like ROS and ADH to hoard every single drop of salt and water they can find. This creates massive volume overload, and, with the high pressure in the liver, all that excess fluid gets pushed right out into the abdominal space.
Section 3. Decoding the fluid. The diagnostic tap.
So we know the mechanics of what's happening, but we need hard proof. We perform a paracentesis to pull fluid out and run 4 major tests: cell count, total protein, bacterial cultures, and albumin. This step brilliantly illustrates how we diagnose the root cause of the fluid. We use something called the SAG, the serum ascites albumin gradient. I know it sounds super complicated, but honestly, it's just basic subtraction. You take the albumin level in the patient's blood, and you subtract the albumin level in the ascites fluid drawn on the exact same day. The resulting number organizes our entire differential diagnosis into 2 clean categories: high gradient causes, which are driven by pressure and plumbing issues, and low gradient causes, which are usually driven by inflammation or tumors.
And that brings us to the magic number, 1.1. If that subtraction gives you a gradient of 1.1 or higher, boom, it points to portal hypertension with about 97% accuracy. It tells us unequivocally that a pressure backup is forcing this fluid out. But if it's under 1.1, you have to start looking outside the portal system for things like infections, tumors, or maybe pancreatitis.
Let's look at Nora's actual fluid results. Her blood albumin is 2.8, and her fluid albumin is 0.9. That gives us a gradient of 1.9. Since that's well above our 1.1 threshold, we just confirmed liver-driven portal hypertension. Next up, we check her total protein, which is 0.8 grams per deciliter. Because it's under 2.5, it rules out heart failure as the cause, which is great. But notice how low that protein is, 0.8. The protein in this fluid contains immune defenses called opsonins. With a protein level that low, her ascites fluid is practically defenseless. She's essentially a sitting duck for a serious infection.
Section 4. Draining the ascites. The fix.
All right, we know exactly what's causing the fluid buildup. Now, how do we get it off of Nora safely? The foundational fix is always salt restriction, keeping dietary sodium between 1 and 2 grams a day. But to really move the fluid, we need diuretics. And the golden rule in cirrhotic ascites is this specific ratio, 5:2. We prescribe spironolactone and furosemide in a strict 5:2 ratio. So for example, 100 milligrams of spironolactone with 40 milligrams of furosemide. We titrate this up together to achieve a safe, steady goal of draining about 1 liter of fluid per day.
But right, remember earlier when I said to keep Nora's home medications in mind? We've got to stop those immediately. Nora takes ibuprofen, which is an NSAID, and lisinopril, an ACE inhibitor. In a patient with cirrhosis, NSAIDs completely blunt the kidney's prostaglandins, which basically renders our diuretics totally useless. ACE inhibitors and ARBs do the same thing, all while dangerously dropping her blood pressure. If we don't stop these meds right now, that fluid is never going to leave her body.
Now, what if we do everything right and the fluid still refuses to budge? Then we face what's called refractory ascites. And this comes in 2 frustrating flavors. First, diuretic resistant, meaning we've maxed out the drugs and the patient is eating perfectly low sodium, but the weight just will not drop. The second flavor is diuretic intractable. This is when the side effects of the drugs like acute kidney injury or drastically low sodium become so dangerous that our own medical interventions force us to stop the treatment. It's an incredibly difficult spot to be in.
Section 5. The infection plot twist. Spontaneous bacterial peritonitis.
So let's fast forward a bit. Nora gets her medications adjusted, she starts losing fluid, and she goes home feeling better. But 3 weeks later, she's back in the hospital. 2 days ago, she started getting confused. Today, she's got a fever of 38.1 Celsius and mild tenderness all over her abdomen. Remember that extremely low protein level in her fluid we talked about earlier? Because her fluid lacked immune defenses, gut bacteria have literally translocated. They crossed right out of her bowel and set up shop directly in the ascites fluid. This complication can be silent, sometimes only presenting as mild confusion, but make no mistake, it is deadly.
We urgently perform another paracentesis to tap her fluid again, and we look for our next magic number. We're looking at the cell count, specifically the neutrophils, which are the white blood cells that fight bacterial infections. If we see 250 neutrophils per cubic millimeter, it means this fluid is infected until proven otherwise. 250 is the absolute line in the sand where we must act immediately. Nora's new lab results come back, and her neutrophil count is a staggering 640. And the cultures? They grow a single organism, E. coli. We have officially diagnosed spontaneous bacterial peritonitis, or SBP. Her own gut bacteria have invaded the fluid. Now, here's where we have to play detective again. We have to be absolutely sure this is a spontaneous infection and not a surgical emergency, like her bowel actually rupturing and leaking into the abdomen. We use Runyon's criteria to tell the difference. We check the fluid's protein and glucose. In SBP, the protein is low, glucose is normal, and it's usually just a single bug, like E. coli. But if Nora had a ruptured bowel, which we call secondary peritonitis, the fluid would look entirely different. High protein, super low glucose because the bacteria are eating it all, and polymicrobial cultures with a whole zoo of different bugs. Thankfully, Nora's results fit classic SBP. That means no emergency surgery, but she absolutely needs aggressive medical treatment right now.
To save Nora, our treatment plan has to be swift and precise. We attack the infection immediately with a 3rd-generation cephalosporin antibiotic, like ceftriaxone. But here is the critical part that is so often missed. We must give heavy, calculated doses of IV albumin alongside that antibiotic. You see, SBP causes massive fluid shifts that can just destroy the kidneys. The albumin acts as a biological shield to protect them. We'll repeat the fluid tap at 48 hours to make sure the white blood cell count is actually dropping. Also, we absolutely cannot do a large volume fluid drain while she's actively infected, because that spikes the kidney injury risk even further. Finally, because this happened once, it's highly likely to happen again. So when Nora goes home, she's going to be on indefinite daily prophylactic antibiotics like ciprofloxacin for the rest of her life.
The good news? Nora survives this ordeal and safely goes home, her fluid managed and her infection cured. But man, her case is just a masterclass in medical deduction, isn't it? By simply analyzing a tiny sample of fluid, we mapped the pressures in our liver, evaluated the strength of her heart, tested the defenses of her immune system, and tailored a precise chemical treatment plan to save her life. It really leaves us wondering, if a single fluid sample can reveal all of those secrets, what other incredible diagnostic mysteries are hiding inside your own body right now? Thanks for joining me on this explainer, and stay curious.